So it's the greatness of the seniors that has allowed us to function. Thank you so much, sir. I'll be talking about prophylactic lasers for certain predisposing lesions which lead to retinal detachment. So why this presentation? We do not want to land up our patients in a situation like this because we missed something like this. Uh, and specifically now the world is under a myopic pandemic, and it is the expected myopes are around 5 billion by the year 2050, and greater number of these people are opting for spectacle removals. But most of them, a lot of patients that we counsel, they feel that their myopia is gone after a laser has been done, but the eye still remains myopic, and the degenerations and all the complications that comes with myopia are still there. Now, there's a study that showed that around 53% of these myopes, they had some sort of peripheral retinal degenerations that were found. Now, retinal detachment has an approximate incidence of 1 in 10,000 people with various predisposing factors like myopia, complicated surgeries, trauma, but we'll be focusing, of course, today on peripheral retinal degenerations. Now, there are a lot of peripheral retinal degenerations that are there. We don't need to know about all of them. We will just focus on the predisposing lesions that can lead to detachment in our patients. So number one, and the most commonly that is found in our practice, is lattice degeneration. Its incidence is approximately around 6 to 10%. The important thing is that only 2.8% of these lattices cause RD. But an even more important statistics is that 30% RDs are associated with an lattice degeneration in these eyes. So others, certain predisposing lesions like snail track degenerations, degenerative retinoschisis, cystic and zonular tractional retinal tufts, a retinal tear and retinal hole. These are the conditions that might require treatment and consistent and long-term follow-ups. A very important event that occurs is of posterior vitreous detachment. Now, this is something that is like a connecting link between a predisposing lesion and a retinal detachment. Now, which can lead to tears at the sites of the firm vitreoretinal adhesions that are there, and especially in these lesions like lattices and CRTs, and which of course gives liquefied vitreous access to the brakes and thus can lead to it leads to the subretinal space and can lead to a detachment. Now, 10 to 15% patients with an acute symptomatic PVD, people having floaters and other things, are found to have a retinal tear. But when you see blood pigments, you see vitreous hemorrhage, you see other pigments, then the risk shoots up to approximately 70%. Now, it's very important to closely follow up all our PVD cases. Basically, all the patients that come to you with sudden onset floaters and other flashes and other symptoms. And if there is a fresh vitreous hemorrhage and you cannot identify the etiology, the underlying etiology, then these should be kept under very close follow-ups with serial ultrasounds, and keep examining the patient till the vitreous hemorrhage clears. Because usually there is an underlying tear, avulsion of blood vessels, which leads to the vitreous hemorrhage. Now, the most important aspect is the management of these cases. Before we start managing, we need to screen these patients and identify the relevant lesions that are there. For this, nothing beats the cost-effective indirect ophthalmoscopy. A lot of the residents that we meet and interact, they're not very proficient with this art, and all of us as ophthalmologists, as comprehensive ophthalmologists, should be proficient in this. Now, of course, we have wide field imaging like optos that are there, but they're expensive, and all of us do not have exposure to these machines. Another pillar of identifying these lesions is a dilated exam. In our center, in my center, we do it for all our patients unless it is contraindicated. But certain conditions, you should always dilate these patients and insist a dilatation. All myopes, one-eyed patients, if there is a history of detachment in the other eye, if there's a family history of retinal detachment, if you're planning any intraocular surgery, be it cataract surgery, refractive surgery, even if you are planning a capsulotomy for these patients, then do a dilated exam. And of course, trauma patients, and definitely patients with sudden flashes and floaters. So this is a very nice article in IGO that came out in 2022 by Dr. Venkatesh and his group about the recommendations. So earlier to this, there were not very clear-cut guidelines that were there. So this article has laid out these guidelines. So peripheral retinal degenerations that need to be considered for treatment. So number one is lattice degeneration with retinal hole, presence of Hosh2 tears or retinal dialysis, presence of retinal hole with a cuff of fluid surrounding it, and traumatic retinal breaks. So these are very important. All of you, this definitely needs treatment. Now, if you see a predisposing lesion in a patient and he has these other associated symptoms like recent onset of flashes or floaters or a PVD, patient is undergoing any surgery, a history of retinal detachment in the other eye, one-eyed patients, and also syndromic patients. If you can spot a Marfan or a Stickler syndrome, then these might need treatment. Now, there are certain additional considerations. If there is a family history of RD, if this means that if there is a predisposing lesion and the patient has a family history of RD, then if the patient is unable to access care or access to retina specialist, and if you feel that the patient will not be in a good follow-up with you, and mentally challenged patients. So you can consider treating these patients. Now, which patients can be safely observed? An asymptomatic lattice. If you see a lattice, there is no hole, there is no symptom associated with it, we can, for all practical purposes, safely observe this case. A lattice with no break or hole can be observed. Pigmented lattices with no breaks and holes, and lattices with even atrophic holes can be safely observed. Now, again, all these cases will need a very good follow-up, and the duration of follow-up is not set out clearly, but I feel at least I do that twice a year, 6 monthly, I try to observe these patients. Now, the same paper had given certain guidelines for a patient undergoing intraocular surgery. So do a dilated retinal exam. If you see a peripheral retinal degeneration which is predisposing to RRD, which we have discussed, treat that patient before the surgery, and then plan the procedure at least 2 weeks after this procedure. So there's a lot of confusion regarding after how much time can we operate these patients. So a fair amount would be around 2 weeks. And then, according to this guideline, a retinal examination is only needed if patient becomes symptomatic, if there are flashes or floaters or anything. Now, if there are no such lesions, then you can go ahead and plan the procedure and examination only if the patient develops a symptom. Now, coming to the treatment part, barrage laser as we call it, now it has proven effective through various studies that, like this paper where the other eye of GRT patients was treated. So the incidence decreased from 43% to 13%, and the macular involvement from 17 to 1.3%. So these are definitely effective. There's another paper which studied the patients undergoing LASIK. So they reported a very low incidence of RD in the patients who had undergone prophylactic barrage laser, which was almost 0.25%. So the equipments, how this barrage laser works, so it generates a stiff chorioretinal adhesion surrounding the lattice. It is considered that the strength increases up to approximately 4 times of normal retina, which helps us in countering the traction that might be there and prevents the fluid vitreous from entering the subretinal space and leading to a retinal detachment. Now, the delivery methods, as Dr. Jitesh has discussed, could be slit lamp or a laser LIO. Now, slit lamp has its own advantages. I feel it's very ergonomically better. Nowadays, I try to do all my, even barrage lasers with the help of a slit lamp delivery system. You have better stability and control, and if you have a multi-spot laser, then it will take lesser time. But there are certain conditions where you cannot avoid LIO. If you have a very peripheral or an anterior lesion where these lenses will not help you to reach, there are lesions which require indentation, children who are under sedation, patients who have recently undergone surgery where you do not want to put a contact lens. And another indication could be when you're traveling, you're visiting other centers and trying to laser, then it's difficult to carry your slit lamp. Now, laser settings are pretty basic. It's around, the spot size could be 200 to 500 microns. Power is 100 to 300 milliwatts, and the duration is around 50 to 300 milliseconds. Now, power will mostly depend on the media clarity. Now, important thing to understand is that at the same energy levels, the shorter duration pulses will cause less pain to the patients. So, and the laser will spread less and less collateral damage will be there. Coming to how we do these lasers, at least 2 to 3 burns covering all the margins of the break should be applied. You can go for more if you feel the lesion is bigger and the chance there's a lot of SRF that is covering. It is very important to cover. Before covering, it's very important to visualize the anterior margin of the break and then cover it appropriately. The covering the edges is also very important. If it is not possible to visualize, then one option is that you can cover it till the aura in that part of the eye, and indent if you have difficulty in visualizing it, or you can go for a cryo as well. Now, what kind of spots would we like? As Dr. Jivtesh had mentioned, moderately white laser spots would do. Begin with faint white reaction initially. So the full reaction takes certain time to develop, and it will becomes fairly dense after certain time. Now, what if we do it very extensively, at very high power? Then there could be hemorrhages that could develop. It can lead to certain traction that can develop near the tear. It is more painful, it can cause more inflammation and chances of more ERM. If you're lasering a very small hole, then it might not be there, but if you're going for a 360 laser in patients, then it could lead to ERM formation. So if you have a too intense white burn is there, then you can also treat that as a lesion, because that area becomes weak, and surround it with low intensity spots. Now, follow-up of these patients, as I just previously mentioned, these adhesive pulses increases over period from few days up to 2 weeks. So whatever surgery or procedure you are planning, there should at least be a gap of 14 days between the two procedures. So another thing is, after the procedure, after this 2 weeks, what should be the follow-up of this patient? So technically, you do not need very regular follow-up once you have lasered, but at least if there are any recent onset symptoms are there, then follow up the patient or maintain the patient in an annual or a biannual follow-up. To conclude, dilated exam with indirect ophthalmoscopy should be for all our patients at least once in their lives, and is must for the condition that I had mentioned. You should be able to identify these predisposing lesions. It's very important to counsel these patients, because what I felt in my practice, there are certain lesions which you can demonstrate to the patient, but this is one lesion which at times you might not be able to demonstrate if you don't have an optos or something. So I try to document these lesions with the help of the 20D lens and my camera. Once the patient sees that lesion, he gets convinced very easily. It's not about the financial aspect of it, but the patient feels that the eyes are normal. There's nothing wrong with the eye, and the laser is being advised unnecessarily. It's very important to educate your patients about the symptoms of PVD or a retinal detachment, and it's very important to document that you have counseled these patients with this. Promptly treat where it is required and follow as per the advice. And I personally feel if you have a doubt whether it is a predisposing lesion or not, it is better to go ahead and treat it rather than to be in a confusion. And if a lot of confusion is there, don't hesitate to refer to your retina colleague. Thank you so much.